Thanks very much. So one of the first key messages is the Woodstone residence. There's a picture, and your patients can go there for free. This was a charity, the Looking Glass Foundation, which morphed into the Woodstone Foundation, bought this place after 11 years of work. It's been open for a year and a half, and the BC provincial government sends your patients there, up to 10 patients at a time, for free. And you just apply through your mental health region, and they're put on a waiting list. This is for anorexia and bulimia and EDNOS only. So it's a terrific residential treatment center. We have about 25 employees. It's the largest employer on Galliano Island, which isn't hard to believe. We've got psychiatrist Julie Gaminovic, myself. We've got a pediatrician. We've got 4 psychologists. We've got family therapists. We've got nurses, mental health therapists. We've got all sorts of things. A huge staff. So this is a fantastic place. I think it's the best residential treatment center in the world, but I'm biased because I designed it, and I'm there 3 days a week. But it is fantastic. We're doing wonderful work. So if you have a patient with eating disorders, you should know that they could go there for free. The government will pay for that. We're also opening another 10 beds. We've got 2 open so far that are private, because the government only allows people 17 to 24, and there's a number of other restrictions that they have to meet. But there are another 10 beds where people can apply from across Canada we've opened 2 so far, and they're full. If you want to learn more about eating disorders, I do have a course through Douglas College, which has 9 different subtypes, ones for physicians, where you can learn about eating disorders. And I was just mentioning to Ralph that if people want to spend a few days with me on Galliano Island as a physician, we would be delighted to have you. You can come and spend a few days with me. You can see the patients with me. You can attend rounds, and you can learn about eating disorders firsthand, which I think might be a real benefit to some of you to see how a multidisciplinary team works. Eating disorders have been around for a long time, and anorexia has been around forever. It's a genetic disorder. Anorexia really doesn't have anything to do with weight and shape preoccupation. This is St. Catherine of Siena, before and after she developed anorexia. Out of all of the women in the world, almost all will suffer weight loss at one point. And by the way, the risk of males getting an eating disorder, including anorexia, is about 1 in 5, not 1 in 20, as we used to think it was. But with marked weight loss, if you have a genetic predisposition, you get anorexia. And the main factor is the weight loss. Anorexia is a terrible disease. This graph, I'm a statistician too, as we mentioned, and I did a study showing that the average person with anorexia that sees me, this is based on 20 years of patients in BC, will live 22 years shorter life than someone who wasn't referred to me with anorexia. It's standard patient in BC. If your daughter got anorexia, she's going to live 22 years shorter. That is an incredible thing for these young women to think. Part of that, by the way, is we've shown that anorexia, every time they stop menstruating and menstruate again, it shortens the telomere, which of course sets the length of our life. So it decreases the length of the telomere, and this is one of the reasons people with anorexia live a shorter period of time. All illnesses have multiple causations, as we know. And this is just a picture using Kenneth Rothman's theory of causation, showing you that probably, and with time, of course, we all have difficulty seeing, but nevertheless, it's one demonstration there. There'll be many routes to anorexia. Could be a head injury, could be a gene. There's some people that actually have antibodies against the amygdala in their blood, etc. But almost always there's weight loss associated with it and a genetic predisposition. Anorexia is really a phobia, and that's the best way for you to think about it. If you remember that anorexia nervosa is a phobia to being fat, you'll get it. And that explains to you why the patient responds the way they do. You know they're starving, you know they're at risk of dying, And I tell my patients, I'm still phobic somewhat to heights, but I used to be incredibly phobic, and I climbed down the Grand Canyon at one point. And as you know, the paths are basically straight down. And it doesn't matter that I shouldn't be phobic of heights, or that I didn't want to be, or that I was embarrassed about it. It's there. The amygdala is one of the older parts of the brain. It responds before the cognitive areas do. It responds to vision before the visual cortex responds. So it's a very strong part of the brain. And once, it's sort of like I tell the patients, it's like a bear that goes into the woods, eats a berry, and gets terribly ill. That bear will never eat that berry again, because its amygdala has registered that as something that it shouldn't eat. So here's the amygdala in the brain lighting up when an anorexic is told about fat or thinking about things. You can even show this if you start an IV and you tell them you're running in glucose, even if you aren't. This is a young lady in Europe. You may remember the history. She was a model in Europe, and a photographer tried to make a point of this. And now in most Europe, it's illegal to have models with a BMI less than 18. What is the ideal weight? Because you're faced with this all the time. Young women come in, and you're told you should prevent obesity, that obesity is bad, that people should eat less and exercise more. Well, what is the best weight? What weight should people be? What are they striving for? Is it BMI? No. I wrote the review of the BMI guidelines years ago, and I entitled it the ecologic fallacy, which just means that what's true in a population isn't necessarily true in an individual. So, for example, you might say people that are more than 7 feet tall are very likely to be basketball players. That's true, but that doesn't mean every individual who's more than 7 feet tall is a basketball player. And so the ideal weight really is more related to these things: optimal cognitive function, normal growth and development, fertility and disease resistance. So really it's about health. And you've got to remind yourself that this varies between men and women, between different ethnicities. We did a study with, I did a number of studies with Scott Laird at SFU showing that, for example, Southeast Asian women have about a 4% lower normal body fat even at birth. We showed this with Jean-Pierre Chanoine at the Children's, even at birth. So that the normal body fat for us varies. So how do you figure out what's the acceptable level? Well, most people use BMI, percentiles, etc., but really you should use things like menstruation. And what I use, if I'm uncertain, is forming dominant follicles. Because quite often young women may still be menstruating if they're under tremendous stress or if they're regaining weight, but if they're forming dominant follicles, that means they're at their ideal weight, or at a healthy weight anyway. So this was some of the research we did showing that different ethnicities have different norms for waist circumference, BMI, and body fat. Asian females have a lower normal percent, and Asian males have higher incremental risk with cardiovascular disease at lower waist circumference. Basically, you just have to remember, and you know this, that different people have different norms. And when the people come to you and you tell them you should be between this BMI and this BMI, obviously if they're weightlifters, for example, a lot of their weight's going to be muscle. So that's going to mean that they have a lot less fat, and they could be malnourished. So you see one of your patients. She's 17 years of age. She's anorexic. You're very concerned about her. You admit her to hospital, and on the 10th day she becomes short of breath. She's transferred to the ICU, and you find out that she has congestive heart failure due to a congestive cardiomyopathy. So what does this do to? What deficiency is this due to? Phosphate. Yeah. So, phosphate, hypophosphatemia, and this is the commonest cause of death in refeeding. And one of your biggest concerns, and one of the reasons that very few psychiatrists will see these patients with you, is these patients die. And they're not like your average patient with depression or schizophrenia. These patients, you know that if you refeed them, they could die. And the key thing about refeeding is that you have to do it slowly and you have to give them the vitamins and minerals they need. So one of the most important things about anorexia for you to recall from today is the refeeding syndrome. And most physicians in BC, most emergency physicians don't understand this. So what I will tell them is it's very much like a building. You're going to build a building in a lot, and you put wood there, and you put nails, and you put all the things you have, and you appear to have a lot of stuff. And you start building, but by the second floor, you run out of nails because you didn't have proportionally as many nails. And that's what refeeding syndrome is about. The amount of nutrients that you need to rebuild your body is different than the amount you have. So you're going to run out of things along the way. On the other hand, if you leave that lot alone and never build the house, it's going to look as if you have lots of things. And that's why anorexics, when they're low weight, generally do just fine. Because their body isn't under the stress of refeeding. You're not causing them to need nutrients. So that is the key factor. In fact, parents will often ask you, well, why are you giving all these nutrients? The blood tests were normal and she's been like this for 3 years. And you'll say it's because when we fire the body up, when we fire this car up that we haven't used for 3 years and haven't taken it out, we know that we're going to probably be down in something. That's when. It's when you take it out for a race. That's when you need to find out what you need. That is a key principle. Now, if you saw clubbing in one of your eating disorder patients, do you know what that indicates? It means that they're using laxatives. This is due to laxative abuse. So laxative abuse in eating disorder patients causes clubbing. Otherwise, you might think they had a cancer or something like that. So this is very common, and it indicates clubbing. This sign was described by a friend of mine, Gerald Russell, who's quite an old man now. He's a character. Every place he goes, every talk we go to, he takes pictures in all the art galleries, and he takes them home, and his wife paints the pictures. Every time. It's got quite this thing he's got with his wife. His wife never goes anywhere. I don't know why. But he's a psychiatrist, so one can only guess. But in any case, this sign is the Russell sign, and it's due to something that doesn't happen that much anymore. It's due to recurrent vomiting by putting your hand in your mouth, and the teeth cause marks on the back of the hand, and that's little scars there. Now, these will go away if they haven't really formed a scar, if there's just some inflammation there, but afterwards they won't go away. And if the patient puts their hand on your desk and you don't notice the scars, and they have an eating disorder, they'll sort of figure you don't know what you're doing. Because you should notice the scars, right? But most women these days, and men, usually don't use their hands to purge anymore. They just will the food out. And that's been a change over the last, I've actually been doing this for 35 years now. And this has been a change over the last 15 years. So here's the hypophosphatemia I mentioned. So it is the most important deficiency. Now, the things to know about phosphate are that phosphate is in a lot of foods, but there's a ton in milk. And of course, most eating disorder patients don't drink milk, but there is a ton in milk and in other foods. And phosphate is rapidly absorbed into your body, so it's easy to give orally. And it moves around the body quickly. So if you eat food, insulin moves potassium and phosphate into the cells, so phosphate moves. So if you do the phosphate fasting, it'll be one level, but if you do it after eating, it'll be lower. So it'll appear to be low if they've just eaten. So remember that it moves around all over the place. And people use a ton of phosphate because, of course, it's ATP, 2,3-DPG, cyclic AMP, all those things. So phosphate is used in huge amounts during refeeding. And in the Second World War, the commonest cause of death with repatriation from the prisoner work camps was hypophosphatemia. It really has to be fairly low to get a significant deficiency, but the key thing is to stay ahead and be giving the patient potassium phosphate. The cheapest form of potassium phosphate is phosphate solution, which is, the pharmacists don't like you ordering this because, of course, it's the stuff you give, to clear the bowel before a colonoscopy. But it has 45 milliliters in that solution of the phosphate solution. and you only have to use 5 milliliters at a time. So it only costs like 50 cents per dose, whereas the potassium phosphate tablets, if you get them, they're often out, cost about $1.75. So it's a lot cheaper, and it's very well absorbed. But if the patient will drink milk, there's 500 milligrams of phosphate in every liter of milk. So phosphate does drop after meals temporarily, and because it is part of ATP, when the phosphate drops, the first thing that happens is they go into heart failure, but after that, everything else, the brain stops, everything, you get rhabdomyolysis, white cells, everything, basically just die. So I'll go over this. So the key thing is to give phosphate during refeeding. 500 milligrams 3 times a day, liquid or tablet, and monitor the phosphate every day for the first week, and then 3 times a week after that. So with early refeeding, you're thinking of, if you've just seen the patient, the biggest concern you have is killing the patient by refeeding, and so you're going to go slow. You're going to start off with like less than Weight Watchers, like 1,000 or 800 calories a day, gradually increasing it, and you're going to give phosphate and potassium. So if we look at the nutrient stores in the body, so these are the stores in you and I who are normal, you can see that the store of vitamin A and selenium is about 17-year store we have. Mind you, there's no selenium in the soil in BC, in Keshan province in China, and in New Zealand. And that's why the cattle in BC have to be given selenium injections, because if we just ate our fruit and vegetables from here, but of course we don't, we eat it from California and Florida naturally. But if we did, we would get selenium deficient. Huge deficiency things here. But for example, there is no store of zinc in the brain, none. So you're already deficient as soon as you stop drinking milk. So you see, there's very little of some of these nutrients, and that's why you can't tell what they're going to become deficient in, because they usually stopped eating normally a couple of years before, and these stores are so minimal. So it's all about supply and demand. So as soon as you start feeding the patient, or if you tell the parents to feed them, or if you admit them to hospital, you're increasing the demand. And if they don't have the supply, that's why they get the deficiencies. So here's some patients. Chronic eating disorder patient has many physical complaints, including worsening rash on her legs. This is pretty rare, but I see this about once every 2 years. Anybody here worked in Africa? Pellagra, exactly. It's Pellagra. So you can even see Pellagra in eating disorder patients due to niacin deficiency. And of course, that's diarrhea, dermatitis, dementia, death. I'm the only person that sees it. I refer to the dermatologist and they say, no, it isn't. But then they have their rounds and they look at it and say, yes, it is, because they never see this, of course. But what this really tells you, if you can get Pellagra, you can get anything. I see copper deficiencies, selenium deficiencies. I had a patient 2 years ago who came in complaining with her husband of decreased vision, and she had a vitamin A deficiency and a retinal binding globulin deficiency. She was blind, partially blind, and that hasn't corrected entirely. Okay, here's a red skin eruption on the legs. Impoverished street girl with severe anorexia asked why she's getting red spots. And these are parafollicular hemorrhages, and it says that they're early scurvy. So I see a couple of cases a year of scurvy. And early scurvy, all they get is the parafollicular hemorrhages on the legs. So where the hairs would come out, it's sort of covered over by the skin. And if you lift the skin off there's a little petechiae in that area. And then they start getting bruises elsewhere, and they bleed when they brush their teeth. And this is easily correctable with, I've even seen one at Woodstone in the last year of scurvy. But we just don't think about this, because we wouldn't realize that these patients eat such weird diets. I've had patients eat nothing but watermelon for 3 months. I mean, there are weird diets, and they're young people who've got fast metabolism, and once you start feeding them. So, principles of refeeding. Start feeding low, 600 or 800 calories a day, and increase calories slow over a few weeks. So this is the key thing, slow and low. And usually the parents and perhaps the patient will say, well, is there something I shouldn't eat? Sweets. Carbohydrates are the killer. So if they eat a bunch of sweets, they're going to perhaps precipitate morning encephalopathy, and certainly they're going to use, they're much more likely to get the problems with refeeding because of the changes in insulin, movement of glucose, etc. You have to repeat lights, creatinine, phosphorus, magnesium daily, and then 2 or 3 times a week. I give everybody thiamine because they can get morning encephalopathy. The last case I had was actually in a VGH nurse, a male nurse, and I was seeing him as an outpatient. He refused to be admitted, and his partner phoned me and said there's something wrong. He said he's acting strange, so he brought him in, and he had an organic brain syndrome, acute organic brain syndrome. He had a lateral bilateral nystagmus, and he had morning encephalopathy, and he was actually taking thiamine. But in his case, it was because thiamine, it requires both phosphate and magnesium to work, so it was because of magnesium deficiency that he didn't have the thiamine. But you have to give thiamine, zinc, and multivitamins. So you give all these things, and you just tell them you have to take all these vitamins and minerals because I don't know what you're going to be deficient in. I can't tell. And the blood tests don't tell us. And you'll notice that almost all the time the blood test will be normal. That doesn't mean anything. I tell them it's like looking in your wallet and saying how much money you have in your bank. Well, it doesn't tell you. That the wallet is the blood test. But most of us will have some money in the wallet even if we don't have any money in the bank. Investigate and treat arrhythmias, postprandial hypoglycaemia. I'm going to those. Now, as you know, these are the components of energy expenditure. And some of your patients will, who are anorexic will get better eating 1,600, 1,700 calories. Other patients will need more than 4,000 calories. I spent 10 years trying to figure out why. And I did eventually. And it's this thing up here. Non-exercise activity thermogenesis. And in fact, Levine at the Mayo Clinic found that this is probably one of the major treatable causes of obesity too. That as we gain weight and we get more fatty tissue, we're more insulated, and so we tend to have less micro movements, fidgeting, etc. And the average obese person burns off 350 calories a day less of non-exercise activity thermogenesis. And that's equivalent to 30 pounds a year. So that's a lot of weight. And we found in anorexics very high non-exercise activity thermogenesis. And I forgot whether I have pictures of how we did it here or not. But this is the key. So non-exercise activity thermogenesis is the energy expended not from sleep, eating, or sports-like activity. And it could be from typing, fidgeting, even sitting upright. But most anorexics, well, you'll see them, they're just, moving all the time, all those micro movements. And that burns off a ton of calories. This is the increase in caloric expenditure by various non-exercise activity, such as sitting, standing, gum chewing, fidgeting, stair climbing, walking, etc. And quite often our patients will be doing all of these. They'll never sit still. And we found a way of treating them too. I perhaps don't have a slide, but the way of treating them, and it turns out I did 10 years of research on this too, is warmth, is warming them up. So we use warming jackets, sun, etc. And that's why there's basically no anorexia just around the equator if the patient has never left that area. No one has ever become anorexic. And that's because heat decreases non-exercise activity thermogenesis. It also affects melanocortin-4 in the brain, which has something to do with anorexia. On the other hand, the majority of anorexia is in colder climates. And that's one of the reasons that you're more likely to have a high weight in very warm climates. I mean, if you were in a very hot climate and you're an exercise, let's just say you're running, you try to go for a run when it's 40 degrees. Has anybody tried to do laps in a very hot pool? You can't do it, right? In fact, this was discovered by the first guy who described anorexia, William Gull, in 1857. In the follow-up letter to his first description, he said it usually occurs in the cold months. And a friend of mine, Emilio Gutierrez, was the one who actually discovered this, and we've been doing research on it since. Okay, so you've admitted your patient, you're anorexic, to hospital, and a 27-year-old is there, and she's on your ward, and she's resistant and manipulative, and you don't do rounds on her, but the person, you know, sort of the person who isn't quite as good as you does rounds on her, and doesn't know her, and he finds that he knows she's resistant and manipulative, and he refuses to talk to her. So the nurse phones you and says, the doctor didn't really talk to your patient, but she's worried about the patient because she finds that she won't wake up. She's tried to wake her up and she won't wake up. So you remember this talk today, and you say, and this is a case that this exact thing happened to me. You say, do her glucometer reading, do her blood sugar. She comes back and she tells you it's 1.9. Patient's hypoglycemic. So this is really common in anorexia. And of course, you're going to give the patient 50 milliliters of 50% dextrose. You're going to keep them on a dextrose drip, etc. But the real question is, why? Well, if we look at the usable calories in the body, we don't use our eyes or our brain or anything like that. So we've got liver glycogen. I'm going to show you how much energy is there. Muscle glycogen does not get in the blood, so you only use it for your muscle. The sugar in your blood is almost none. So basically, it's all body fat. But body fat can't be converted to sugar immediately. And your brain, as you know, only uses sugar for the first 24 hours. After that, it can use ketone bodies. And if we look at liver glycogen here, you can see the amount of time that liver glycogen lasts, not very long. And so if you get a patient who's malnourished and has very little body fat, they will use up their liver glycogen. Now, when you or I, if we eat a meal, sugar goes into our blood, we put out insulin from the liver, the sugar goes down, we put out glucagon from the pancreas, and that props up our sugar by releasing sugar from the liver. But what if you don't have any? You get hypoglycemia. So this is the cause of hypoglycemia in these patients, no liver glycogen. So if they're recently malnourished and you haven't renourished them, when you start feeding them, they're going to get hypoglycemic. We might say, well, why would that happen when I start refeeding them? Because that's when they put out more insulin. So this is an incredibly important point. When you start feeding them, not only do you deplete their deficiencies, but they don't have any liver glycogen, so their sugar is going to go down in response to the meal and insulin, and they're not going to be able to correct that. So hypoglycemia occurs early in refeeding. And you have to monitor that. I usually check the patient's sugar 30 to 60 minutes after meals, and we all know that they could get this. If they get it, basically you have to put them on IV or have them eating every hour or two. So this is a very important thing. Now I was the first person to report the use of glucagon test to see whether they were likely to get this. In the glucagon test, just like we do for diabetics, but here I give them the glucagon to see whether they can mount an increase of sugar. So if you're wondering about this, you give them a milligram of glucagon, and if it's a flat response, if it can't go up, that means they have no liver glycogen. All right, so here's the patient that we talked about, or I talked about before. So that you admit this, or you don't admit this meal. Males won't be admitted to hospital, and they won't go to residential treatment centers, etc. So if you get a male with an eating disorder, generally they are worried about any treatment because they think it will label them. They're worried about being labeled as gay or something. And not all patients with eating disorders are gay, but whether they're gay or not, really they should go for treatment. But in any case, so this is typical. So this is a 24-year-old male nurse with anorexia who wouldn't be admitted. So this is just typical because these patients won't be admitted. He's eating all these vitamins. He develops a confusion, ataxia, nystagmus over a period of 1 day. And just as we mentioned, he got this. He got Wernicke's encephalopathy. So Wernicke's encephalopathy means they kill off around the third and fourth ventricle, mammary bodies, the aqueducts, are killing off that part of the brain. And for about a day or so, this is potentially reversible. After that, it goes into Korsakoff syndrome, and for the rest of their life after that, they can't make new memories. So basically, they're institutionalizable. So we got him, and he reversed. And if you treat them very early, they reverse in an hour or two. Now, this is a very important point, too, because most of the patients with anorexia you see are going to be chronic anorexics. They'll be around in your community or one of your colleagues before, and they've been anorexic for 10, 15, 20 years. So this is one of these patients that's been anorexic since she was 12, 25-year-old with anorexia, and she is admitted for refeeding, but she presents with jaw pain. And so you look at her, and she's got no fever and no white count. So you think, she's got no fever or white count. But the investigation showed osteomyelitis of the jaw. This is a real patient, and she had a huge osteomyelitis of her jaw. And that's because, we were the first people in the world to show this, anorexics have an abnormal immune response. You may notice, if you remember your patients with anorexia, they don't get viral infections. When the flu goes around, they don't get it. And that's because they have decreased interleukin 1-6 and tumor necrosis factor alpha, so they don't get viral infections, but they can't mobilize white cells to fight off bacterial infections. But because the white cells don't mobilize, they also don't get a high white count or a fever. And they usually present about a week and a half, 2 weeks later. So instead of presenting with pneumonia, they present with emphysema. Instead of having a small abscess under the tooth, they present with osteomyelitis. So you really got to remember that they don't get viral infections, and that's because of their immune problem. In fact, when they get better, they'll start getting viral infections. This has happened to a few people recently at Woodstone. They got the flu, and they say, I'm feeling terrible, I got the flu. I said, I'm happy. I'm happy getting the flu. It means you're nutritionally recovered. That's great. But if they're sick, they also will not show these bacterial infections. So if they have them, you've got to have a much higher index of suspicion. So if it's a urinary tract infection or a chest infection, you have to remember they're not going to have the normal signs. Here's another thing I did, actually 12 years of research on was zinc deficiency. Zinc deficiency presents in your patients with, and zinc, by the way, is primarily in milk. So that's why most of these patients are going to get zinc deficient. Remember I said that there's no store in the brain of zinc. So it's dependent on the daily intake of zinc. So if they're not drinking milk, and soy milk doesn't count, they'll have all these other types of milk they're drinking. You'll say, do you drink milk? Yes. What type of milk? Some weird type of milk they drink. But we're talking about regular cow's milk for zinc. But if they don't drink that, they're not getting enough. And that changes eating behavior in animals almost immediately. They will change their eating. And what they get is dysgeusia. And your patients get a change in taste. So either things will taste metallic, or they'll want to eat a certain thing, or they'll want to have extra spice or salt, things like that. With iron, of course, the commonest one is pagophagia, or wanting to have very cold beverages. And it does cause impaired immunity, which is particularly obvious on the skin. And the young women particularly be very concerned because zinc deficiency prevents their skin from healing. So if they have cut themselves or they get cuts or something, it won't heal. And if you say, how long has this cut been here? Been there for 2 months, it just doesn't heal. Put them on zinc and it heals. Just oral zinc. And here's a case of a patient with acrodermatitis enteropathica. So it's primarily the soles of the hands, very dry skin with cracks. Now, I did all this, we finally did a randomized double-blinded placebo-controlled trial of zinc, which actually the World Journal of Psychiatric Pharmacology suggests that our work puts zinc as the medication with the highest degree of proof for use in anorexia of any other medication. Just came out, so I was quite happy about that. And we found that the patients on zinc, whether or not they were zinc deficient, gained BMI twice as fast as patients who weren't. And there were other reports around the world for people getting better, but I'll just go back. So you might say, well, how does this work? It turns out that zinc modulates gamma-aminobutyric acid in the amygdala, which helps dopamine and serotonin sort of balance out. So basically, it affects the cause of anorexia in some cases. And there have been cases of anorexia who recovered just with zinc. I'm not suggesting your patient's anorexia is due to that, But I do write the Canadian guidelines for anorexia and bulimia in the therapeutic guidelines book, and you'll notice that zinc is under there for both of those. Okay, another patient of yours, 28-year-old female with anorexia nervosa and psychogenic polydipsia. About 2 to 5% of people with anorexia will have psychogenic polydipsia. And with eating disorders, the difference between eating and drinking becomes sort of numbed. So they may restrict, or they may do a lot of these things, and it doesn't, they sort of overlap. So this patient comes in, you know she has psychogenic polydipsia, and you find that she has a low sodium and she's volume depleted. So I know you wouldn't do this, but someone puts her on normal saline, and then she develops a decreased level of consciousness. And of course, this is the mnemonic for this, the good old raisin and grape thing. You change her from a grape into a raisin, or a raisin into a grape, depending upon which way the osmoles are going. And this is central pontine myelitis. So this is a cause of death in anorexia, which isn't uncommon. So if patients have low serum sodium, you got to change that very rapidly. As you know, the brain can change the osmolality inside cells. It has idiogenic osmoles, which are proteins that they can break up or divide up. So they can change the osmolality, but that takes days. So if the osmolality in the blood, if the serum sodium is low, the brain changes to match that. But if you rapidly change that, it can't change that quickly. So the patient will either crenate or explode their brain, and if they explode, they get all the pressure on the pons and then they die. Now this is not an uncommon thing at all. So you have a patient who you know has had an eating disorder in the past, but they appear pretty well. This was a nurse too. And she comes into hospital just for surgery. She seems to be quite stable. And they did the blood tests on admission for this patient. But remember what we said about the blood tests. And the blood tests appear to be okay, but she complains of leg cramps. And then a few days post-op, she has a seizure. And then the next day she has a cardiac arrest. And this is due to magnesium, my favorite mineral. I love magnesium. It does everything. But here's a study I did with one of my students to make this point. So and this is like, magnesium is 99% in the cells, right? There's almost none in the serum. But, so really the blood test doesn't tell you much at all. But even there, this is the blood test being low. And you can see this was coming into hospital, eating disorder ward, the number of days, up to 16 days, and the one on the x-axis, the y-axis, we have the percent patients with hypomagnesemia, low serum. And you see that it happens over time, which really means we're uncovering the low magnesium. So this is just another thing that just because she has the normal blood test doesn't mean she's not deficient. And the clue here was the muscle cramps, which is the commonest sign of total body magnesium deficiencies and muscle cramps. The other signs these people get, they get impaired short-term memory, and they also get, fascinating to me, is impaired accommodation of their eyes. So they'll be able to read, but their eyes will go out of focus. And they present with headaches, but eye problems. They go to the ophthalmologist. The ophthalmologist looks in their eyes, says you're normal. They go home. They go again once or twice, and eventually they get a prescription for reading glasses, which costs them $300, which they don't need. Because it's just because the ciliary muscle in their eye is weak. So when they're trying to focus, it goes out of focus after a while because the muscle is weak. All the muscles in the body are weak with magnesium deficiency. Okay, so now I can replace this. I have so many patients on intravenous magnesium over the years, but one patient I had on, her daughter was 35, and she was getting 5 infusions a week. And the mother looked high and low on the internet and everything, and she found the solution to this, which oddly enough is blackstrap molasses, which we use at Woodstone all the time now. It turns out that the problem with magnesium, of course, is it's a laxative, right? Like Magnalax, milk of magnesia, magnesium citrate, etc. So if you give people magnesium orally, it just zips through them. In fact, they lose more magnesium than they get. Now, intramuscular magnesium works pretty well, but it hurts a lot. And intramuscular or intravenous magnesium means you got to have an IV for 4 hours. But it turns out that blackstrap molasses is absorbed, I guess because it goes so slowly through the bowel. So my new treatment for magnesium is 15 milliliters of blackstrap molasses 3 times a day. And most of my patients have been able to come off intravenous therapy for magnesium deficiencies. Blackstrap molasses also has a ton of iron and other nutrients in it too, but blackstrap molasses is the is the basic one without being with all the nutrients being taken out. We don't need that anymore. Abdominal pain. Okay. So an 18-year-old emaciated female is admitted for feeding. She complains of nausea and abdominal pain. And the nurses report she vomits after eating. We've had a number of cases in the last few years of this. Now, the first thought most people has it, well, it's their eating disorder. They're vomiting up. But what if the patient said, no, I'm not vomiting, and I'm getting pain down there? So this is a rare disorder in the world, but actually common in eating disorders. Whoops, no, it's not. It's not there. It's called the superior mesenteric artery syndrome. So basically what happens is you lose all the fat in your abdomen, and the superior mesenteric artery crushes the duodenum against the aorta. It obstructs the third part of the duodenum is obstructed, and the patients can't eat. So remember that sometimes these things can be due to something else. They can have another cause. In fact, there was a patient who died 2 years ago up the valley from pancreatitis, who I think was not considered by myself and others as maybe having that because she had eating disorders, and they often get aches and pains in the tummy. So it just reminds us that we got to think, could there be something else? We were the first people in the world to show that anorexia causes emphysema. It's the only medical cause, only reversible cause of emphysema. So anorexia actually causes decrease in the amount of lung tissue. Now, we don't know whether this is due to stem cells or just nutrition, but it's fascinating that anorexia affects the lung that way. However, most people with anorexia you see will be short of breath, and almost always it's just because their diaphragm is wasted. We showed this a long time ago, so they lose at least a third of the muscle in the diaphragm. So even when they recover, because it's a smooth muscle, so it takes a few years to recover, they'll still be short of breath on exercising. This is the mortality rate from various psychiatric disorders. So there's depression, schizophrenia, schizoaffective disorder, etc. So you can see how dangerous anorexia is. This is a study I did of 20 years of patients. This is another way of looking at it with the standardized mortality ratio of 10.5. By the way, the definition of anorexia nervosa and bulimia and binging disorders is changing. The DSM-5 is about to come out, and I'll tell you the changes. So for anorexia nervosa, they're dropping the 85%. You had to drop down to 85%, it's just drop. They're dropping the amenorrhea. You don't have to be amenorrheic. And those are the two biggest. And they're also the subtype binge eating, binge purge or restricting is just the last 3 months. It isn't sort of forever. Bulimia nervosa, it's dropping the requirement for binge purge from twice a week to once a week. And the new disorder is binge eating disorder. Because bulimia nervosa, they're no longer going to have a non-purging subtype, so it's just going to be transferring into binge eating disorder. So people that just binge and don't purge will not be called bulimia nervosa non-purging subtype. Okay, 17-year-old anorexia admitted for refeeding, complains of palpitations. I've had a number of people who have died. About 27 of my patients have died. Most of them have died of dysrhythmias. Some of them, thank heavens, have had these in hospital, and one of them actually had just across from VGH, but they usually get torsade de pointe. The same thing when you read about on Danzatron recently when they got that handout about torsade de pointe. So this is how they die. So who should you be worried about that they could die? Like, what are the risk factors that you would measure to tell you that this person might die of a dysrhythmia? Well, if they're getting symptoms consistent with no cardiac output, like faintness, loss of consciousness, chest pain, seizure, palpitations. Also, if the ECG shows a QTC greater than 440 milliseconds, now you'll notice that's a lot less than what you're told for middle-aged men like myself across the hall there when they told you the 550 or something. This is because young women's QTC is different, so it's 440 milliseconds. Even more than that, I look at the change in QTC. So someone had a QTC of 320 and now they're 430. You know, there's something happening. And low potassium and magnesium are risk factors too. But we reported in fact, that the cause of death in anorexia nervosa isn't due to the heart after a number of years looking at the heart. It's actually due to change in autonomic control of the heart. That is a rapid change in heart rate variability, which is the same cause of death after heart attacks in middle-aged men like myself too. It's actually not the ischemia, it's change in heart rate variability. And this all has to do with autonomic dysfunction. So almost all the signs in anorexia that are weird are due to autonomic dysfunction. Because when you think of it, if they do have a phobia, if their amygdala is frightened and not frightened, frightened and not frightened, frightened and not frightened, their heart rate's going to go up, it's going to go down. And when you're terribly frightened, as you know, your bowel empties and then it stops. Your bladder empties. Your blood goes away from your extremities and into the center of your body. Your carotids stop working. Your pupils get large. So all of these changes, can you imagine if you had a car where you thought you had to go very fast and then slow, all of a sudden on and off all the time. And this is what happens in anorexia. So we find anorexics who sweat in the middle of the night on and off, or get a very fast heart rate and then get a slow heart rate, or their bladder doesn't work and then it works. So this, if you remember the autonomic changes that they get, that explains so many of the findings. And this is why many patients will get large carotids without binging purging, simply because the carotids don't empty and they get larger and larger. That's why we treat them with warming. The patients who have had dysrhythmias due to this, I treat with metoprolol beta blocker to stop these changes. So these are the organs you know that are affected by the autonomic nervous system. And they're all the organs that drive my patients nuts. Their eyes, their heart, their digestive system, carotid gland, etc. One of the commonest signs you'll see in anorexia is just lanugo hair. And most of you, I'm sure still deliver babies. I never see them. I'm separated even. I don't even see my kids that much. but I remember what this looked like. And this fine hair is lanugo hair. And lanugo hair is exactly the same as their regular hair. It isn't a different color, and it does go when they get pregnant. All right, so here's some final messages here in the next couple slides. First, how to avoid killing your patient. Before you do much, correct the existing deficiencies. So if you do see someone and they have deficiencies, even before you're refeeding them, correct those deficiencies first. So if they've got low potassium and you haven't even treated them yet, correct those. The second, correct volume depletion and check renal function. Now, most of your patients, when you see them initially, will be dehydrated, will be volume depleted. The thing is, if you don't treat this off the bat, they will get a huge retention of fluid. I've seen patients gain up to 25 pounds, and they become edematous, and they will not go forward with treatment because they think you're getting them to gain too much weight. But if you give them extra salt and water, like Oxycube and that sort of stuff, get their volume normal, they'll retain less salt and water. Give thiamine before glucose, so you don't prevent Wernicke. So 100 milligrams a day of thiamine. I give it for 30 days as an outpatient. Measure potassium, phosphorus, and magnesium daily, and correct any deficiencies. So what you're going to see with these quite often is that things are okay initially, but then the potassium will drop, or the phosphate will drop, or the magnesium will drop. So you have to change how much you're giving them. Give prophylactic potassium and phosphorus. And calories start low and gradually increase. So these are my suggestions. Now the patients will ask you, what are the irreversible complications of my anorexia? Are there things I can't get better? Well, if they die, that's not correctable. Short stature is one of the commonest things. If you see people before they've reached their full adult height, they will no longer grow if they are malnourished. And if they haven't closed their epiphyses, they've got a chance to grow. But sometimes if they know that they're not going to grow, they want to be able to grow, get height. Permanent loss of memory. Wernicke-Korsakoff is a terrifying thing to many of these patients. And if they do get magnesium deficiency or phosphate deficiency, I tell them that this could lead to a permanent loss of memory. Loss of teeth. Many of my patients lose their teeth by the time they're 30. Can you imagine for a young woman losing all their teeth? And to get a full set of everything costs like $60,000. I've had patients do that. So, but even if they've still got the eating disorder, that's all going to go anyway. Impaired smooth muscle function for years, so bowel, bladder, diaphragm. So that means that for years afterwards, for example, they will not be able to jog or do anything like that because their diaphragm is weak. Missing or recycling adolescence. I asked them, you know, how was puberty? You know, if they did go through it. And I would say, how would you like to go through that every year for the next 20 years? Not fun, usually, right? And low self-esteem, mood disorder, and inadequate education. So remember, osteoporosis. Well, actually, I think we'll leave it here. We've done a lot of these things. And if you want to find out the real answers, you just look at my book, the most recent version, the second edition, Cambridge University Press, Medical Management of Eating Disorders, is this one here. And this is a picture I took of a cactus blooming in Death Valley. How's that for being appropriate? These are some of the reviews. Thank you.